Hi, this is Dr. Desmond again, gastroenterologist. Today I want to talk about a feeding tube. Okay, so last episode we talked about nasogastric feeding tube, NGT, nasogastric feeding tube. Today I want to talk about other tube. We have one type of tube that is called nasogastric tube. That means from the nasal through the esophagus, through the stomach, and the jejunum. The good thing is that they bypass the stomach, so we can, for people that have a lot of gastric content, we can bypass that and we can feed them. The problem is, if you can go to the jejunum, the tube has to be usually very small. The nasogastric jejunal tube we have are very small caliber and they get blocked very easily. I more or less gave up using that because I think it's very traumatic to keep changing the tube. So nasogastric tube, the main problem is that it can cause sinusitis, it can cause some esophageal problem, some narrowing because it's keep using the esophagus, and also it get blocked very often. Every 1 or 2 months, doctor have to keep changing the tube, especially when the family use it to feed medication. Medication, no matter how much you pound it, they will become, no matter how fine they are, they will choke up more easily. So we can actually put in the bigger tube, but you obviously cannot put in the big tube from the nose to the stomach, because if you do that, it blocks the nose and they can't breathe, and it becomes very uncomfortable at the nose and the back of the mouth. So then we have to talk about this thing called percutaneous endoscopic gastrostomy tube, or PEG. It goes to the skin, we put it through the scope into the stomach. There's a little balloon at the end of it as an anchor, so they cannot yank out easily. With this tube, they are much bigger. They are 2 to 3 times bigger in caliber as compared to the NG tube. So a bigger tube means there are many advantages. Let me go through that. A bigger tube means we can feed more quantity, we can feed more viscous kind of feed without fearing that they block. We can even pound the medication and serve medication, so it's easy to do. It's also less discomfort on the nose, less anxiety that the tube is over the abdomen. They wear a shirt, a t-shirt, they cover that up. They can bring their grandmother, their elderly mother outside. Nobody can know they have a feeding tube. And the tube don't get blocked. We don't have to keep changing it. In fact, my patients get PEG tube, percutaneous endoscopic gastrostomy tube, PEG tube, often last for 1 year, 2 years, 3 years. They just come back every 1 or 2 years. We just change the new tube because the old tube get very dirty, get moldy, sometimes get choked. Okay, so but to put the percutaneous endoscopic gastrostomy PEG into the stomach, there are 2 ways to do it. I do it through the scope. What we do is that we put the scope we put the patient to sleep. We put the scope from the mouth to the stomach. From the stomach inside, we find out where's the best part. From the outside, my colleague will poke through the tube, and then we pull the tube inside. So we insert it through the scope, PEG, E7 endoscopy, percutaneous endoscopic gastrostomy tube, PEG tube. So we put it inside. That's very good. Now, some family member don't want the risk of a scope, so they choose to do it radiologically, whereby I don't do it. My colleague in the intervention radiology will do it. The patient lie flat. They will look for the stomach with the ultrasound scan or CT scan. They put the needle in, they dilate the tract, and they put the tube inside, blow a balloon and to anchor it. So they insert the feeding tube radiologically. So then I got one particular patient, the daughter asked me, should my mother is now on the NG tube, she do a PEG tube? The question is, nobody know for sure. Between the nasogastric tube and the PEG tube, they have the pros and the cons. PEG tube, they need to take the risk of a scope to insert the tube. There's a risk of bleeding, there's a risk of infection. But the good thing is that it doesn't get blocked so easily. It can feed medication, it can feed more viscous feed. So it's better than NG tube, whereby the tube get blocked and the medication can choke it. So patient have to decide. To put in the feeding gastrostomy tube, whether we should do it through the scope or do it through X-ray, there's been no comparative study, head-to-head randomized control trial, but many studies have shown that they're the same. Success rate is the same, risk is the same, risk of bleeding, perforation kind of thing, infection, they're the same. So to sum up, we can put the nasogastric tube between this and the PG tube, probably similar risk, similar effect, but they have different kind of profile. PG tube, small risk of the insertion of bleeding and infection, but it lasts longer. NG tube, the risk of infection and bleeding less, but then the tube may last only 2 months, 1 month, they need to keep changing it. How to insert the gastrostomy tube? Either through the scope or just through X-ray guidance, pros and cons, they are almost similar, similar risk, similar kind of profile, similar kind of blockage rate. So at the end of the day, I would say that NG tube, PG tube, gastrostomy tube inserted through X-ray, they have similar efficacy, similar risk of complication. How we do it depend on the operator, depend on the patient's preference, depend on the family member's preference. So at the end of the day, I had to throw the question back to the doctor and say that they are probably equal. NG tube, PG tube, radiology inserted percutaneous gastrostomy tube, they are probably similar, but they have different risk profile, different side effect. You have to decide, and I would work with you. I hope I talked to you about feeding tube. And this is Dr. Desmond White, gastroenterologist again. Thank you.